And now I'm delighted to invite the next speaker, Dr. Magnus Hald, Senior Consultant Psychiatrist with the Drug-Free Treatment Unit, University Hospital of Northern Norway in Tromsø, Norway. Beautiful place. I was there once at your conference. For more than 10 years, until 2018, for more than 10 years, until 2018, he was director of the Division of Mental Health and Substance Abuse at the University Hospital. Has long been interested in the development of a network-oriented approach to mental health challenges based on ideas that have come from his working with reflecting terms and reflective processes. This approach, together with a recovery-oriented perspective, has been central to the development of the treatment program in the Drug-Free Treatment Unit. Thank you for being with us today.
I think I have to pick this up. Thank you very much for that nice introduction, and thank you for inviting me here. You must bear over with my somewhat limited command of the English language, but I'll try to give you a presentation about this drug-free treatment unit in Northern Norway. First of all, I would say that this treatment unit is basically established to help persons with serious mental problems to choose treatment that does not focus on antipsychotics, or rather better neuroleptics, because you all know that these drugs, they don't really work on psychosis, they work on the brain. Sometimes that might be experienced as useful, sometimes not, and they have all these side effects that we have heard about, and there are different sides to this that I might come back to. So the establishment of this was basically a wish for a choice for people with serious mental problems, as if people did not have a choice within our ordinary system. And that's been a big debate about what is it having a choice, and why don't people experience that they really have a choice. So I'll talk a little about this. First of all, about the Norwegian context, why drug-free treatment, the mandate we got to establish this unit, the medication-free program, and what we have achieved. And this is a map showing you Norway, and you see Tromsø is far, far to the north. So I'm from very far away. And I noticed today they were talking about experts coming here, and you know experts, that's a little man from far away. I'm not that little, so you know I'm not an expert. But anyway, this is Norway, and Norway is very much a democracy, and I think it's the very strong democratic tradition in Norway, I think, is one of the reasons why we got the drug-free treatment option. These are, you know, different characteristics of a democratic society. And in a democratic society as Norway, you know, we have mental health care, which is basically a public system. And we have the primary health care that's organized on the town level, and the specialized health care organized in 4 different regional health trusts. Northern Norway is one of those regional health trusts with a population of about 450,000 or 480,000, and it's not very many people, but it's a very huge area. For a long time there have been 2 central messages for developing the healthcare system in Norway, and one has been that we should have the patient healthcare system. It seems like professionals often think that the healthcare system is developed for the professionals. And when we plan healthcare, it's generally planned by professionals or by providers. But there has been a strong message in Norway that we should include the users or the patients, both on the systems level and on the case level. And like the health secretary said in 2015, the basic question is, if the patients were given the right to decide, how would we organize and run the healthcare system? This is a radical question. The answer we get should be taken seriously, and it should be decisive for the work with the patient's healthcare system. So that was one very strong drive for developing the drug-free treatment unit. And the other drive was the so-called golden rule, which you might know as the law of reciprocity in many religions, the principle of treating others as one would want to be treated oneself. But in healthcare in Norway, The golden rule is that treatment programs in mental health and substance abuse shall have higher yearly growth than programs in somatic medicine. So that's been also a strong message for healthcare. Although it's not been really possible to live up to this, it's been something that we have been aiming at. But you know, somatic medicine has a very strong drive of technology that makes it easy to use resources, so to speak. So in 2010, when there was established a joint action for drug-free treatment programs in Norway, it became very difficult for the health ministry to say, well, we don't want this, because there were 5 user organizations that joined forces and demanded a drug-free treatment option. So that was a very strong drive in that direction at that time, so it became politically impossible not to follow that, since we're a democracy where you're supposed to take also minorities into consideration when you plan things and do things. So for 5 years, the health ministry said to the different regional health trusts, well, you have to establish this, and nobody did anything. And then in 2015, there was a special message, a special letter from the health ministry telling the health trust that now you have to do something. You can't ignore my message anymore. So he said that all patients treated with medication should have plans for tapering and termination, which is a very strong message, which still isn't followed in Norway. And he also said to obtain experience, establish at least 1 drug-free bed unit in each region. And that is the bed unit in Northern Norway, where I have worked then for the last 7 years, and also include user knowledge on an equal basis in the planning process, which is very different from other planning of healthcare in Norway, that the users have this very strong position in the planning process. So the user organizations and the regional health trust together developed a protocol that we had to follow when we were to establish this drug-free treatment unit. So it was decided, and we also had a lot of opposition from, central psychiatrists in Norway that wrote things like this in the Journal of the Norwegian Medical Association. And there's been an ongoing opposition amongst a group of professionals against the effort to develop drug-free treatment possibilities. Well, there was developed then a regional protocol that told us what this drug-free unit should look like, what we should secure choice. Like I said earlier, it's a part of a major effort to reduce the use of psychotropic drugs, based on, and it should focus on cooperation and in very many respects have a network perspective. So that was a central part of the message that we got from the protocol, from the regional health trust and the user organizations, and in addition to that they had these criteria for admitting patients. We ran into different problems with these criteria, which I will come back to, but the criteria also has resulted in the situation where we get a very motivated group of patients coming to our unit. There are people, and there are still patients that really have to fight to get into our unit, because all referrals have to come from the specialized healthcare system, and there are not all places that want to refer patients to our program. So when we started to organize this, we early on found out that there was no national or international experience with developing programs like this within the framework of the healthcare system. There were some earlier attempts. We looked into the Soteria programs in Europe at that time, and they used more drugs than we did in the ordinary healthcare system in Norway. So it seems that many that work on Soteria ideas still use more drugs than we were used to. So we didn't really find any good models. And we were also supposed to establish 6 beds in the middle of a regional hospital. There are several hundred beds in this region for psychiatry, and not that many in the hospital, but also with psychiatric centers and nursing homes and things like that. So there are quite a few beds, and we were only to have 6 beds for this population of 480 people, 80,000 people, and a very, very big catchment area. So how could we do that? This in a good way. And we early on decided we have to be very network oriented, and we wanted to establish the unit as a part of the of the network of psychiatric facilities, so to speak, because we found that it was important for us to be a part of the ordinary system. We didn't want to be marginalized by being said, well, this is something that takes place outside of the system. And I think also much of the criticism of our program is because we're a part of the ordinary system. How can, people say that we should be a part of the ordinary system when we kind of collide with some of the basic ideas in psychiatry? So we use this network or web-oriented metaphor both for planning and in clinical work. When we plan psychiatry, it's very often planned according to a kind of metaphor of a chain where you're supposed to have the right tasks at the right places in the chain, and where people are transferred from one part of this treatment chain to another, and kind of losing all their contacts in this other. So we tried to use more of a web perspective when we organized. And in the web, you have more shared responsibility. It by itself enhances cooperation. Knowledge seems to be more democratic. In a chain, you will have kind of transfer of knowledge from one level to another, but in a network, you will more have exchange of knowledge, and then also develop more local knowledge and more knowledge that is relevant. So the idea of hierarchical knowledge will be exchanged for the idea of more democratic knowledge. And we also, a network perspective or a web perspective also emphasizes continuity. And in working with this, we especially draw on these people here, Tom Anderson, and the work with the reflecting processes and reflecting team, which was developed in Tromsø in the late 80s and 90s of the last century, and also with the work of Jaakko Saikulu, which many of you might have heard of in Western Lapland. We have had a close cooperation with the Open Dialogue people since the 80s. So we thought of the drug-free treatment unit as a new possibility in the mental health treatment web. And very concretely, when we work clinically, in Norway when you have a patient with serious mental problems, the person will generally have a contact with a local psychiatric center, and the local psychiatric center can then send a referral to the drug-free treatment unit, and we will then contact both the patient and the local psychiatric center and ask, well, who's engaged in your situation here? Who should we talk to, or could we have a conversation with people engaged in this situation? And then we say, well, there are more people engaged in my situation here, the patient might say, or he might say it's not. But anyway, we will then have more people, and some of these different players here will have a contact with one another from before, and we will say, well, we would like to gather as many as possible, and then we would gather people in a meeting, and this was what we would then call the treatment web. So this would be a kind of simplistic presentation of that. So we have what you might call a web-oriented referral process, where we get a written referral from the service system and the patient. So we get two referrals, one from the patients and one from the service system. And then we have a meeting where we ask certain questions and try to develop certain questions. First of all, to get a kind of common ground for seeing if it's feasible or good, or if it's a thing for this patient to be a part of our program, or this person to be a part of our program. And also, we discussed in this first meeting what the drug-free treatment unit's role should be in the treatment web. So we're not, like you often see in healthcare, taking over, we're becoming a part of a treatment web. So the day we receive a referral, we become a part of that web, and we try to define that all the way through the program. So the role of the drug-free treatment unit will then generally be to organize network meetings throughout the process. And the thing is that when we base things so much on network meetings, patients don't have to stay that long in the ward. Very often they will stay for 1 to 3 weeks, and there will be long periods at home, or sometimes with a local psychiatric center. And this means that we can include very many more patients in our program than we could if we only had 6 treatment possibilities. So at any time we will have more than 30 patients in our program. And we will also organize the stay in when patients are in the unit, typically 1 to 3 weeks, like I said, we have a general program that people have to follow. Some people say, well, it's a lot of work being in the ward because there is a daily program that contains very many different things. And we also have an individual program for each person that's created while the patient is in the drug unit and in the unit. And sometimes we also have some individual follow-up between the stays. In addition to network meetings, which might be both when the patient is in the ward and between the stays. So the drug-free treatment unit, we base what we do on, I think, 2 or maybe 3 different principles. First of all, we're this network or web-oriented perspective, and then secondly, a recovery perspective. And then at the core of this, I would say, we have a relational perspective. I think relations is what this is basically about. So we try to have all these perspectives kind of permeate what goes on whenever patients are in the ward or whenever we have contact with patients that are in our program. So with recovery, there are very many different things can be said about recovery. When we ask people, both patient and people working in the ward, what do you think about when we talk about recovery? These are some of the answers that we get, and I think empowerment is a very central part of recovery. And we also have a recovery workshop that originally, daily recovery workshop, 4 or 5 times a week for 1 hour. It was originally inspired by the IMR that you heard about earlier today, but we found that model too medical. So we have gone away from that, and especially the drug part of that model is very changed from what it is in the IMR. And we also have a strong emphasis on physical exercise when people are in the ward and also between stays, because it seems that almost or more than half of the patients that we get into the ward, they have they're using drugs when they're being referred, and more than 90% have used drugs at some point in their career. And it seems that drugs, one of the side effects is that people become kind of not able to do physical training and things like that. So we have a lot of emphasis on that also, that also people take home with them, actually, different training programs, for instance. We have also art therapy, we have music therapy, there are some mindfulness groups, so there's a lot of things going on in the ward, which many patients say that they experience as one of the biggest differences from other wards, when we try to have our principles with us into all these different activities. I said that we ran into some problems when it comes to the criteria of admitting patients. First of all, in Norway, to get voluntary psychiatric care, you have to have the capacity to consent. If you don't have the capacity to consent, you cannot receive psychiatric care voluntarily, like you can in very many other countries. But you have to have that in Norway, and that means that we're supposed to apply to these ideas of capacity to consent, which I think is a good idea in one way, but it's also difficult to, well, when is the capacity good enough, and when is it? I mean, there are many aspects to this, especially if the capacity to consent changes during the course of treatment, which it might do. We use a little what you call psychiatric advance directives. You know what that is? It's that you make up some ideas about how you want to be treated in a situation where you don't have many symptoms or in a situation where you have the capacity to consent, you can make plans for what you want to do when you don't have the capacity to consent. In Norway, that doesn't have a legal standing. Okay, we should also give priority to patients with psychosis or bipolar disorders. So what then about patients that don't want to have their problems classified in that way? Well, we really don't pay much attention to diagnosis because we know that there are problems with diagnosis, and we are basically helping people that elsewise would have been given neuroleptics. So if people say that if I don't come here, I will be given neuroleptics, or that's what I've been offered, or that's what I've used, we'll say, well, then you qualify for our program. So we don't care that much about diagnosis, at least I don't, but some people do. And of course there are different ideas with different people working in this setting. We should have referrals only from specialized services, and what about those that don't trust other parts of the mental health service system, which we see quite a lot. Many people have very bad experiences, and we also will generally accept referrals from patients that don't get through the specialized system if they have, well, with some limitations. But to us it's been very important to be able to establish some kind of treatment web, or to be able to co-create that with the patient. So, and that's a challenge when you're not referred from the system. No acute admissions. Well, that's one of the big discussions that we've had, and we have decided that we let the patients that are in our program, or that we have been in contact with, when they have more acute problems, we will still have them admitted, as long as they can cope with staying in an open ward where you have to take responsibility for your own situation. We were not that good at that in the beginning, but we've become more good about that, about accepting that people really are able to take responsibility for their own situation. We thought that, you know, then people left the ward and said, well, I want to go and jump off the bridge here now. We thought that we had to follow them. Now we can say, well, it's your decision. We would like to help you. And people will generally want to be helped. So it's been a change in that for us. Only safe therapeutic procedures. Well, there's a question within the public system, but how far can you go in accepting other ways of dealing with mental health problems than what's accepted in the guidelines and different kind of regulations. And tabering psychotic drugs prior to admission, that's been completely impossible to develop a system that does that, because so many patients have very big problems getting off or tapering neuroleptics, and we will come back to that tomorrow, talk more about how we have worked with tapering and how we do work with tapering. So the main achievements, well, I would still say that we have put this thing on the agenda. It's still a very big debate in Norway. There are debates all the time in different places. I mean, over the last month there's been a big debate in the major Norwegian newspaper about the reason people with serious mental problems don't take their medication is because they're ashamed of it. And why are they ashamed of it? They're ashamed of it because there are some professionals that say that they would help them to get off. So there are all these discussions all the time, and there are also some written articles. For instance, this from the which is some psychiatrists in southwestern Norway that interviewed one another and called it qualitative research, and they all agreed that well, we have to follow guidelines here and we should not offer drug-free treatment. And there are also service users that have done research on this. And I also think that different sides of the use of neuroleptics have been highlighted, and so that's an ongoing debate also, both in Norway and in different other places. But for instance, in our hospital, since we're a part of the hospital, it's been more so that you have to talk more about what you do when you give people medication. We can ask, well, when you tell people about the side effects, what do you tell people? Do you tell them that their brain will shrink, or is that too much? Do you tell them that from day one they'll gain weight, their blood sugar level will rise, their lipid levels in the blood will rise? Do you tell them that? Or don't you? So what is it to give good information about medication? That's been a debate that's come out, I think, partly of this. And of course we're a part of the international discussion about diagnosis, which many of you have heard of. For instance, in Belgium, they say, well, we shouldn't use the DSM diagnosis. The DSM-5 system was, developed because they thought there were more research that could give some kind of basis for the diagnosis, which when they made up the protocol, they found out it really wasn't. So many of the creators of the earlier versions of the DSM system, they propagated very much against the development of the new. So we're a little part of this debate also. And in addition, there are some patients that have received treatment that is more in line with their wishes. And there's a French television documentary, there is a radio program and an article on BBC where some of these patients are quite vocal. And we are also working on research projects. First article is just been sent in now, which is a qualitative research project concerning the patients that have had the offer of drug-free treatment, or the program in our unit. I think in Norway, I think that we can clarify or identify two different directions for mental health, so to speak, and I'm not quite sure if it's possible really to unify these two directions. And we're clearly on the user-oriented side. And I think it's a problem now that the government is at the same time advocating for both these positions, but I don't think that will be possible in the long run. I think they will have to decide, and we are in one respect now under threat of being closed down, not due to an evaluation of what we have been doing, but because resources maybe should be used elsewhere in the system. So that's one of our big struggles now, which is, well, we still don't know how that will end, but that's where we are now. Okay.
A wonderful quote to end with, right? Thank you, first of all, for such a comprehensive overview of a fascinating topic in which most of us, even if we read or heard about, didn't really get to feel firsthand like that. And there's room for maybe one or two questions, but not the obvious elephant in the room, how do we get a passport to Norway? That's even without seeing the pictures of how beautiful it is. So, Rola, b'kasha.
Hi. I was a hypnotist also, and then I was thinking about if your people may be present in Israel, maybe they don't need even hospitalization. So why did you open like a bed unit and didn't do it like an open day or like day treatment or something like this? Because your patients are not acute crisis and they are after the tapering down and without the drug, massive drug problems. So why do you need to hospitalize them in bed unit?
Well, we started the bed unit because that was our option. That was what the user organization said, we really want a bed unit. But at that time, I really thought, well, maybe we should work more outpatient-like or have day programs and things like that. But I found out, or my experience is that the bed unit is really offering something to the people that are coming. Because we have this daily program that people seem to think is very useful. Many people feel very much, or describe that they feel very much heard and seen in a different way. So we have, I think for many patients, we have been able to establish a different experience with the mental health care system, both for the patients and also for ourselves as professionals. And one thing I didn't mention clearly enough is that there's a strong, in the ward we share much more experiences than what's been generally been considered advisable within the healthcare system. We have employed a couple of experts by experience, but also other personnel will share more of their stories when it seems to be useful. And this makes it possible to be in more, I mean, this seems to be an important part of establishing some kind of relations that many patients haven't really experienced for a long time. So it seems like that. So my experience is that it seems like a good idea for us to have a bed unit.
Do you keep in touch with them
we keep contact with the patients for a long time, so it differs a little in which way and how we end the program. We also had patients that have been through everything, and they, after a year or two, they say, we would like to come back. Could we come back just for a stay and see how things are and to share experiences and things like that? So that's been, and we also have some people in the ward that stays in contact with certain patients. So, but we have to always try to find out why do we do things, and that we do it because we find it's a good reason to do it.
Sorry, we won't have time for more questions. I'm sure it's fascinating and much more. Once people want to learn and ask, we'll have an opportunity in the break. Just for the sake of keeping on the program, thank you so much.